Sure. All right, now we got it. All right, so chapter 25 is all about chronic disease management. And why is occupational therapy involved in chronic disease management? What kind of approaches we take? With chronic diseases, who do you think it's more important to be educated on the disease? The practitioner, the family, or the patient? With chronic disease management, okay, so some of these listed up here. Who do you think it's more important to be educated on? Us, the patient? Okay, so why is it really important that the patient is educated on their disease? Huh? Because they have to live with it. What does chronic mean? Is it going anywhere? No, it's not. So each one of these things that we're going to talk about today, we've heard about before. They're not new, with the exception of CHF, but we're going to talk about it in 26 really in depth. So how do these different chronic conditions that we've learned about before, how do they affect these different areas of occupation? What about diabetes? How does that affect things, Allison? Okay. Okay. Very good. Downgrade the activity. Okay. What else is a really important thing with diabetes? What do they struggle with a lot? Wound checks, absolutely. Healing, they heal very, very slow. Something as simple as, when they're cutting their toenails or whatever, if they pull the toenail off the wrong way and it starts to bleed and they have this, sore there, that can take something that's, normal. That can take a really long time and lead to a really dangerous infection for someone who is a bad diabetic. That has to go into account with all things with these. CHF is congestive heart failure. We're going to talk a lot more about that in a little bit. But these kind of people that get out of breath really, really quick, their heart is literally failing them. They are going to need a lot of rest. They're going to need a lot of energy conservation techniques. These people are going to have swollen extremities. They're going to have swollen hands. A lot of the time it's swollen feet and legs. COPD that we've talked about a little bit. How did that affect different areas? Remember that lady we watched the video one that she went throughout her day and how it affected her? Maggie, how does COPD affect the care of pets? Yeah. Right. Okay. What about bathing? How does it affect bathing, Isaiah?
Well, if they don't have a way to sit down during bathing, like standing during bathing can be a lot more the humidity from the heat.
Yeah. Can someone with COPD who's on oxygen, can they take it off when they take a shower? What do you think? Yeah, I'm getting a couple on that. Faith, can you take off oxygen off of a COPD patient while they're taking a shower? The answer is absolutely 110% no, never. COPD patients, they have to have that oxygen. As that supplemental oxygen is really what's keeping their breath. If you take their oxygen off of them, you're putting them at risk for heart attack, for stroke, a lot of different things. Fibromyalgia or chronic pain syndrome, or chronic fatigue syndrome, sorry. Jennifer, how would that affect someone's eating and meal prep? Yeah, just to modify the task, make them break it down a little bit. Yeah. One we haven't really talked about, but we treat it all the time, is obesity. What about caring of others? How does that affect it, Lindsay?
I just feel like if somebody has difficulty getting up or something, like
Okay.
what they need to do to take care of people, and like say they have to take care of kids, obviously their diet is probably very good,
Mhm.
so they're not gonna
Like healthier. Yeah, absolutely. So basically, each one of these chronic conditions or chronic diseases really does affect all areas of occupation, right? You can literally point out one area at least in each one of these categories where these things will affect it, right? So one of the first things that we're going to start with is self-management. That's probably the biggest and most important defense that we can teach people with chronic illnesses. This is defined in your book as an individual's ability to manage the symptoms, treatment, physical, and psychosocial consequences of living with a chronic condition. Teaching these people techniques, energy conservation, or task modification, whatever it is, in order to live, a more independent lifestyle to what they want, right? So, are we going to teach somebody who has COPD if their spouse has always been the one that does the laundry? Are we going to teach them how to do the laundry? No. We're going to focus on things that they are more concerned on, their bathing tasks, their dressing tasks, stuff like that. Whenever a client is diagnosed with a chronic disease, one thing that we're going to talk to them about is how to cope with it. Okay. We're going to help try to increase their quality of life, all these different areas. We all use self-management strategies. We don't realize it, though. We all have issues, whether it be a chronic illness or something later down the road, personal issues, whatever, and we all use self-management strategies in some way. We all cope with situations in certain ways. We have our own thing. Remember last semester in 208, we talked about, what are your coping strategies for stressful situations? And some people listen to music. Some people like to exercise. Those are self-management strategies. They're coping strategies. Now you have to take it into the next step to somebody who has a chronic illness or disease and help them find a coping strategy if they can't find it on their own. So why is self-management so related to OT? Why do you think that is one of the biggest things that we're going to talk about with chronic illnesses? Maggie, why is it so important? Very good. What is that called? A holistic approach. Very good. That's perfect. It is a holistic approach. We're going to look at their performance patterns, like their habits, roles, rituals, and routines. We're going to look at the context of physical, personal, temporal, all these areas. And then lastly, we're always going to make sure that we do occupation-based interventions, advocacy, health promotion, wellness, and prevention. There's different types of occupational therapy intervention in all these areas, and we're going to talk a little bit about those in just a second. There is a theory or a model out there that's called I want you guys to write this down. It's called the TTM. This is the Trans Theoretical Model of Behavior Change. Let me repeat that. It's the Trans Theoretical Model of Behavior Change.
TTM.
The TTM, yep.
Not TTMBC.
TTM. So look on page 650 in your book. We're going to be in your book quite a bit today, so you might as well just keep them out there. A lot of good tables and stuff. So what this model is saying is that if someone needs to make a change in their health, in their daily occupations, they go through certain stages in order to make that change. The first one is the pre-contemplation. This is where the client is considering trying to make a change, but they have not done it yet, or they're not considering it, sorry. They're not considering making a change. They are not They don't feel like there's an issue, no need. Okay? It's on 650. You got next is contemplation. This is where the client might see some benefits of changing. They're starting to come around to the idea, but they're hesitant on it. They also see the benefits of not changing. Well, if I have to change, or if I don't change, I won't have to do this, group activity. I won't have to follow this exercise plan, all this stuff. Then you have preparation. This is where the client has decided to try to achieve a change. They're actually going to start putting forth the effort. Okay. Then you have the action stage. This is where the client starts to actually make the change. They're taking action to start making the change a reality. Next, you have the maintenance. This is where the client is now consistently doing the change that they wanted to do. They've put it in the routine, and it's lasted for normally a little bit longer than 6 months. Then your last two is the termination. This is where the client has made the behavior changes permanent. It's just now part of their routine. It's something they do every day or whatever the change need to be, if it's weekly, bi-weekly, whatever. And then sometimes they go through this, sometimes not. They have the relapse. This is where the client reverts back to an undesired behavior. Okay. And they can go through the cycle afterward. Just because somebody's gone through a relapse doesn't mean they can go through it. The way that I like to kind of think about this is, New Year's resolutions. It kind of, like, oh, I'm going to make the changes here. I'm going to eat healthier. I'm going to go to the gym, whatnot. And they go through these stages, and then they go to a relapse, right? And then they come in and they're like, oh, I've gained such and such weight or whatever. Okay, I need to go back, and they start enacting the behavior again, right? When you go, or the next one is the Canadian Occupational Performance Measure. I'm not going to touch a whole lot on that. It's the COPM. This one is basically just identifying barriers to what's keeping somebody from making a change or reaching a goal. It's all about identifying barriers. Okay, find out why they can't do something. Okay. And then the last technique here is the motivational interviewing. Let's see, it's on page 252. There's table 25, 2 down at the bottom. It says 652, I'm sorry. My bad. It's Monday, I apologize. 652. So you have two different types of questions. Okay, when you're interviewing a patient, finding out what their goals are, why you can't do something, why you should do something. There's two different ways that you can do this. There's defensive questions where you're going to create a response from your patient that makes them be defensive about whatever behavior that they're having, right? So someone comes up to you and said, why don't you want to? Why can't you? These types of questions, that's going to make you defensive, right? That's going to make your whole purpose in this conversation is now I have to defend myself against what you're saying. I have to give an excuse for my behaviors, right? Rather than asking those type of questions, you can ask guiding questions that allows for more of an open conversation of finding things like, why might you want to make this change? If you decide to make this change, how would you do it? Theoretical kind of questions. If you were to do it, how do you think you would do it? And, let them be the guiding answer there, right? The last thing you want to do is, go in and see a patient and immediately start asking, well, why don't you do this? Why don't you do this? Or have a non-cooperative patient say, why don't you do your home exercise program? Why don't you do this? Because you're just going to throw them off. You're not going to get good outcomes. You're just going to make them angry, right? It's important to understand, what their habits are, but it's also really important to address them in the right way. I've addressed smoking several times with patients. I'm like, listen, you have COPD and you're smoking. This is a double whammy. How can we make a change to where you can stop smoking a pack of cigarettes a day. Now, anyone who's ever been a smoker or has family members or friends that are smokers, trying to get them to quit cold turkey 99% of the time does not work. And they always have a relapse, right? Most of the time. So how do you, with something that is addicting as smoking, but we know it's super, super bad for your health, how do you talk to a patient about decreasing their cigarette use? Okay, Maggie. How do you tell me? I'm your patient and I smoke, I have CHF or COPD and I smoke a pack of cigarettes a day. How do you address that with me? Okay. All right. How would you address it, Faith? Hmm?
I know some people that have not as good, but like to me,
Mhm.
and then you have to like commit to weaning
Right.
off. Like this is not just one switch next.
Mhm.
So if they're really motivated and maybe that approach.
Yeah. What about like getting other disciplines involved? Like even talking to their physician, like so and so is really interested in stopping smoking, is a patch, good for them. Could you talk to them about that or some, ways that you can help? Now you can't go in and prescribe, nicotine patches to the person, but you may say you might want to talk to your doctor about that, right? You have to kind of gauge your questions when you're doing health promotion with a patient. There's a lot of things that you can say, hey, check into this, but of course you can't prescribe anything to them, right? Or tell them like you have to do this or you have to do that, things that are outside of your scope of practice. Let's talk a little bit about the psychosocial stuff. So when someone's given a diagnosis of a chronic illness, think about, things that are important to you, your family, or your friends. Say you were given a diagnosis of COPD. So you're really struggling with breathing, even with an oxygen tank or concentrator or whatever, you're still short of breath. And it's very limiting to where you can go and do things. How would you feel if you couldn't do, an activity whenever you wanted to do it? You had to really plan it out. That's the kind of things we kind of take for granted. You want to get up and you want to go to the grocery store. You can do those things, right? You want to get up, you want to go to the movies or something, you can do those things. Your able-bodied can go do it, right? Now, get in the world of somebody who literally has to plan out every single minute of their day so they don't get too worn out and end up, too short of breath. A lot of patients will overdo it with COPD and they'll wipe them out for days. Their muscles just don't have that oxygen coming to them to help them recuperate, and then they're down for 2 or 3 days. Think about how that would impact your life and how limiting that would be. I've worked with a lot of COPD patients. That lady I've told you I've worked with for over 2 years, COPD, had lung transplant, went in rejection, all this stuff. I mean, she's been through a whirlwind, but the freedom that she got when she got her new lungs was insane. And she couldn't even go anywhere because of COVID. But just not being attached to a concentrator or to an oxygen tank all the time, and how much of a difference it made for her, just in her happiness. She could go to church and not have everybody looking at her because she's got 8 liters of oxygen run through her nose all the time. It makes a loud noise. It's uncomfortable. How would you feel if a family member or friend couldn't do these activities with you? Think about the other side of it. So-and-so's spouse, they used to go, and this is actually a pretty common thing, but they like to go dancing. I've had several patients that like that, and then they could not go dancing anymore because their spouse or friend or whoever, is limited to where their oxygen tank can go. And unfortunately, I mean, you guys have probably seen the little concentrators that look like purses you see on commercials. You ever seen them? They're real small. Those are awesome, but they only go up to a certain amount. I think it's 6 liters, maybe 8. A lot of COPD patients are on more than that. And insurances won't pay for that because it's cheaper to get a old school oxygen tank pulled into your house and leave it there, or a big concentrator and leave it at your house. The thing about insurances are they're not so worried about your independence or your happiness. They're all about what fixes the issue for the cheapest. I've only had a few patients that were, those concentrators like $4,000 or $5,000. And I don't, a lot of people in Appalachia, they don't have $4 or $5 just sitting around to spend on a concentrator because they're at home. They don't have any way to, make money. So, and then lastly is how would it affect interpersonal relationships? I think, you guys can see how just even with COPD, with all these, it's going to affect your relationships in every way. And a lot of times you address happiness with patients, just how happy are you? What is something that you'd really, really like to do that you're unable to do now? And do your absolute best to find a way for them to do that. Sometimes it's not, if they tell you they have CHF and they want to do rock climbing, it's probably not going to happen, but find something. Maybe you can go watch if they would enjoy it. Maybe you can take them and watch somebody do it. Find a way for them to be involved. All right, so self-monitoring and lifestyle modifications. We talked a lot about lifestyle modifications already, but self-monitoring is another big one. Go to page 653 in your book. There are some things, an idea of what's called resistance, okay? So there are going to be people, no matter what you teach them about their chronic disease, and this is the right behavior, you need to do this, they're going to have resistance against you, right? They're just not going to agree with you. They're just not going to implement these things. So you need to recognize what a resistance behavior looks like. First one up there is arguing, constantly interrupting. So they're not listening to what you're having to tell them. They're going to respond. You're saying you need to check your oxygen. Oh, no, I'm not doing that. That takes too much time out of my day. That kind of thing. Negativity or denial, blaming, or withdrawal or ignoring. These are all resistance behaviors. And you have to recognize these with your patients, okay? Ways that you can generate resistance that you have to be careful for is the first one is using the writing reflex. The very first thing you should, unless it's a safety issue, is correct the patient. How much do you guys like that? That you feel like, how do you like being corrected on everything? Doesn't feel good, right? Saying these people are human, regardless if you're their patient and you're there to help them. Don't sit there and correct. Break it up a little bit, right? Address the big issues, work your way down to the small. You can't go in and start pointing fingers like, listen, you're doing this and this, and expect them to catch it all and receive it positively. It's just not going to happen. The next thing is using a judgmental or a confrontational approach, like going back to the idea of smoking. Well, don't you know that smoking kills so-and-so, and start quoting statistics at them? They've heard it. They're going to be hard pressed to find a person that doesn't know smoking is bad for them, right? So don't go in and start judging their situation, and you don't know what the situation is. The next one is insisting on change. Like, you have to change. No, it's their life. They can do whatever, they want. And then last is discounting the patient's feelings or motivations. Always take those into account, especially with health promotion. All right, so how can we prevent or minimize that resistance? Understand the client's motivations and desires. Give them choice and autonomy. What does autonomy mean? Choice. It's just another way of saying choice. They have control over their body and their situation. Offering the client options and choices instead. Don't go in and say this is the way it is and that's the only way. Definitely give them options and choices. Let them be a active member in the treatment process. And then use reflective listening. They say, well, the reason I started smoking is because I'm stressed. I have 2 kids and I'm low income right now and these situations, and this is my escape. Help them find a healthier escape. Like, I understand, but this is a really detrimental behavior to your COPD. We need to talk about healthier ways for you to cope. I understand this isn't going to be an overnight change, but it's something that we need to work towards, right? Okay. So when it comes to nutrition and medication, there are certain things you guys can do and certain things you cannot do. Look at these 8 things up on the screen here. And I want to go through and take a little vote, on each one of what you think is inside our scope of practice and things that is outside of our scope of practice, okay? Things you can and cannot do. The first thing is, can you recommend a specific diet for a patient, like paleo or gluten-free? No. Does anyone say yes? No.
Could, but it's probably not a good idea.
Right. It's not a good idea. Don't do it. Don't recommend a specific diet for a patient. That is, you're not a dietitian and you're not their physician. Okay. Number 2 is recommending an over-the-counter herbal supplement. Can you do that? No. Something as simple as saying, hey, I take melatonin to help me sleep at night. Maybe it'll help you. Can you do that? No, you can't. Because what if there's a drug interaction with this over-the-counter herbal supplement and you kill them or put them in the hospital? Never, ever recommend specific medications, okay? 3, recommending a daily pill sorter. Yep, definitely. That's definitely in our scope. What about recommending an app with medication reminders? Yep. Recommending an exercise class or a facility? Few yes. Yeah, definitely. What about recommending adapted positions to a current yoga practice?
Sure.
Absolutely. Definitely. What about recommending low-fat substitutions for a favorite recipe? This one tricky. What do you think, Maggie? Okay. It's just a simple change. It's a swap. Yes, you can do this. This is if they have CHF or they have a history of a heart attack from a blockage, whatever. And somebody's like, oh, I like to, deep fry everything I eat. And, we know that's not good, right? You're not saying, okay, you need to go on keto or you need to go on a low sugar diet or whatever. Just say, you might want to try, swapping out. You really like cheese, there's low fat options for that. Maybe try that. See if it helps your numbers. Oh, you got a really bad report from your doctor on your cholesterol levels. Try a low fat diet for a little while, or a low fat substitution, not diet, low fat substitutions. See if that helps. What?
Low fat usually subs out sugar for fat.
Well, I mean, just in general, with patients with diabetes, you can educate them on their specific diet, but you can't change their diet, because they have diabetes. There's certain foods stay away from, certain foods, do eat, don't eat. That kind of stuff here is standard. You can absolutely educate on that, but you can't be like, you need to be on a diabetic diet. You know what I mean? They already know that. Their doctor, when they diagnosed them, was like, okay, stay away from this, this, this. You can't be like, you need to switch to a diabetic safe diet. And then number 8 is recommending when to do exercises. That's definitely in our scope. Very good. All right, so energy conservation and activity modification. Go to page 656 and 657. Think of a friend or family member. I'm going to move through this kind of quickly, but I want you guys to read over those 8 questions. Think of a friend or a family member with a chronic disease condition. So COPD, diabetes, CHF, any of these areas. And ask these questions to yourself. Do you think that it would be received well? Would they be very willing to make these changes? Or do you think they would be hesitant to make these changes? So can the activity be done in a different way or make it easier or safer? Do you think that you could talk them into something like that? Do you think that they could change the task and do it a different way? Can the activity be done in a different position or with the use of supports for positioning to reduce symptoms during participation? A lot of people won't use positioning devices because they're big, they're bulky, and they think they're embarrassing. They don't want anyone to think that they are different in any way, and they don't like to use them. Number 3 is, can the activity be done at a different time or in a different day when the individual may have more energy or is not in as much pain? Can equipment be used to assist with activity completion? Can rest breaks and breathing techniques be incorporated? Can the activity or task be prepared or organized in a different way? Can assistance be given? That's a big one. A lot of people don't want help. Don't help me. I'm not at that point. You don't need to help me yet, blah, blah, blah. But you can tell that it's definitely an issue, right? I always, when I go through these questions, I kind of think of my grandma who's she makes spaghetti literally every Sunday and has for 40 years or more. And, I try to help her with things. No, I got it. That's the kind of situation I'm talking about. She is unsteady on her feet. Trying to get her to listen to any kind of thing is very difficult. Working through and the last one is, can medication or modalities such as moist heat or a cool pack be used before or after helping these with this activity? So think about some of the friends or family members that you guys thought of, and think if you tried to change whatever task they really enjoy doing, if they are somebody who, takes pride in having a clean house all the time, dust all the time, all that stuff, very proper, that kind of thing. If you tell them, no, you really don't have the, breath here, you have COPD or whatever, and, you can't be doing that kind of stuff every day. It's going to wear you out faster. How easily is something like that received? You take somebody's daily routine and I say, if someone comes up and says, you can't have coffee every morning, I'm not going to receive that well, right? Think about your daily occupation. Someone comes up and just throws in something that you do every day or in your routine and say, you can't do that anymore, or you have to do that in a different way. It's not really received right off the bat, right? We get confrontational about it. You do not have to do this knowledge assessment to turn it in, but we're going to do it as a class, okay? You have 2 questions. By the end of this chapter, you should be able to answer the following 2 questions. Which is a good recommendation for a college student with diabetes who has erratic and busy schedule, or has an erratic, busy schedule with poor eating habits? What do you think is a good recommendation for this patient? We'll take a vote on it whenever you guys are ready. Whenever you guys are ready, just tell me what your answer is. B, okay. This is a super good question that is worded exactly how your board exams are. And the next one's even better. Okay. 2 A's and a B, okay. What else we got? A, okay. Let me stop the record. 3 A's and a B.